ESTO trial was actually done to look at if patients who actually are intended to receive intravenous thrombolysis and thrombectomy should just get undergo thrombectomy. So it's a single arm trial. And the trial was done in multiple centers in Turkey and United States. And essentially, a historical control was used to define the threshold of rates of functional independence. So obviously, we did not find the rates of functional independence to be lower or actually be lower than the group if you just gave them intravenous thrombolysis. So we are actually taking away intravenous thrombolysis. We want to make sure that the results of intravenous thrombolysis are replicated in the group once they get mechanical thrombectomy alone. So 72 patients were actually recruited in the trial, and the rates of modified Rankin scale 0 to 2, which is what we use to define functional independence, were much higher than if those patients would have been treated with intravenous thrombolysis alone based on historical data. So in that sense, the ESTO trial actually showed that doing mechanical thrombectomy alone without the use of intravenous thrombolysis does not produce results that are in any way worse than if those patients would have received intravenous thrombolysis. And it kind of puts the premise on how do we develop this field further and how do we conduct clinical trials. But I think that there is an increasing amount of data, but more data is still valuable because, as I said, that there is considerable variance in the settings. Some places rely heavily on patients being evaluated at a peripheral site and then being transferred to a comprehensive stroke center. Some places, the system has already said that a patient goes straight to a comprehensive stroke center. And the difference in these settings can have considerable influence on the result of the trial. So I think that's why it's important to do trials in different settings to make sure that mechanical thrombectomy alone can meet the parameters under various settings.